talk about imaging in Marfan syndrome. I have shown or briefly alluded to some of the things in my previous talk. Again, I have no financial disclosures. Imaging is crucial in Marfan syndrome. As I alluded to, in 2017, every Marfan patient should have an understanding of what their maximal aortic diameter is. You need to know, just like your social security number, you need to know what your aortic root diameter or aortic diameter is. And there's boatloads of technology nowadays, and I'm sure you guys have had these, or at least some variation of these over the years. Echocardiography, the sonography of the heart, where a sonographer puts a probe on the chest, or if you are unlucky, your doctor orders a transesophageal echocardiogram where there's a tube passed into your food pipe to take some pictures. Many of you may have had a CAT scan or an MRI of your aorta. Essentially, the reason for doing imaging, advanced imaging, is to make an initial diagnosis of not only the aortic disease, but of concomitant valve lesions, the conversation about mitral valve prolapse, systemic lesions, so other things, bony problems, spine problems, lung problems, diagnosis of complications. So to make a diagnosis of somebody complaining of acute chest pain, is it dissection? Is he having a heart attack? Is this just a bad case of heartburn? And also post-operative follow-up. Imaging is crucial in all aspects of management of patients with Marfan syndrome. So cardiovascular manifestations, obviously aneurysm and God forbid dissection. These are the key diagnostic criteria. Aneurysms can occur anywhere. Generally, to avoid the ramifications of radiation or what have you, echo is typically the first-line diagnostic modality for a given patient. It is crucial, as I'm gonna go in the next few slides, it is crucial that the measurements are made in a consistent fashion and they're made right. Garbage in, garbage out. If you have bad measurements, you make bad decisions. That's not good. So as I alluded to, echocardiography is the initial modality. So the image on the right, the moving image, the top moving image is from a patient with a big aortic root, okay? This is from a big aortic root, and the color image on the bottom is showing the flow of blood. This is where we used to recognize if the blood is flowing back. To answer the question from earlier in my talk, if this patient has a lot of leakage, the blood would be gushing back from the aortic valve. That would be what we would use to make a diagnosis of aortic regurgitation, and is the valve repairable? Do we need to replace the valve? What have you. As I alluded to, it is crucial to do the measurements the same way every single time, okay? And that means, first you have to develop the rules of the game. Before you can play the game, you have to develop the rules of the game. So in echocardiography, you have to identify leading edge to leading edge when the heart is relaxed, okay? Do not have to recognize the word diastole, but this is something that we do. And from a perspective of a younger individual, the measurements have been used in the past to generate what is known as a Z-score, okay? This is pictures from 1989 talking about aortic root nomograms on echocardiography, and basically there's 3 different charts that I'm showing. One is for children, adolescents, the other one is young adults, 20 to 39, and the third graph is unfortunately where I have started to fall in now, 40 and over, more mature adults, let's put it that way. So this is a range, okay? There is a range. So the boxes, the shaded boxes, is where the numbers are expected to fall, and they increase as your body surface area increases. I'm going to point out one thing where there is some flaws with this. I'm sure you guys know about you heard about body surface area and stuff. So you could be 5'2" and 150 pounds, and your body surface area is X. 2 years later, you could still be 5'2", and your weight is 210 pounds. Your body surface area becomes more. And most of the aortic dimensions are indexed, meaning you put the aortic dimension on the numerator and the body surface area on the denominator. So paradoxically, at the same height, if you were to become more chubbier, your Z-score goes lower. That doesn't make sense, does it? So we'll come to that in a second. So Z-score for aortic root, there's different criteria. It is important. A lot of times people, experts, even experts, forget what I just told you. Couple of things. Z-score is different up to age 15, for age 20 to 40, and over the age of 40. And everything is indexed to body surface area, which is where there is a limitation to indexing everything to body surface area. Echo, before I go to the CAT scan, echocardiogram, is very much dependent upon the sonographer measuring the images. So if they are recording the images that are not optimal, sometimes Marfan folks have pectus or shallow, or rather, where the chest is indented. The images may or may not be optimal, or the sonographer is not the sharpest tool in the shed, and they make errors in measurements, or the measurements are tangential. Rather than going this way, they go this way. There's lots of errors that can be introduced. And as I said, garbage in, garbage out. So it is important, at least for the folks that see patients, I never base my opinion on somebody else's measurement, unless I know that somebody personally. So if Sagar were to report a CAT scan, I may be okay. But I would still remeasure it. Certainly, I would measure anything and everything that is sent to me from outside. No question about it. Okay? CAT scan, especially for older, more mature individuals like us, where radiation is not that much of an issue. CAT scan provides the best bang for the buck in terms of precisely understanding the aortic pathology. Okay? And there's different protocols that we use. One size does not fit all. If I'm looking for aortic aneurysm in the belly versus near the root versus in the arch, or the full picture, these things, we can tailor the protocol to minimize the radiation. And in fact, our radiation doses at the Cleveland Clinic, we work very hard to minimize as low as reasonably acceptable, which means our radiation dose is probably, I got more radiation going back and forth from Europe this week than some of you may get with some of the ultra high-end CAT scans. As I showed you, you acquire data in 3 dimensions, which means you can play with the data on the software to create fancy views. The fancy colors, they are just for show and tell. But where we are using is precise reconstructions, like the panel on the bottom left, where you can have a precise look at the aortic root and do precise measurements. No other technique offers you this level of precision in a reproducible manner, where we can, your CT from today versus last year versus last year versus last year, you can serially monitor for growth. These measurements are made in 3 dimensions, okay? So we don't just measure randomly, we create short axes. We create such donuts, like the panel in the middle. We create such images to do precise measurements. There's a wrong and a right way of doing things. Okay? This has to be crucially understood. I know these are advanced images, but everybody should be able to understand. The top image, if you draw a line there and do a measurement, that reads as 12 centimeter aorta. Okay? But if you do the correct reconstruction, it is certainly not 12 centimeter aorta. It was measured the wrong way. You'd be amazed as to how many radiologists in the community measure measurements like that, the top panel, and scare the bejesus out of the patients and the referring doctors, and all hell broke loose. And, then we do the measurement. You are sitting in my office. I'm looking at you and say, no, you don't need surgery, and you think I'm a fool. But this is the important thing that needs to be recognized. Normal dimensions, we have normals. For the kids in the room, there'll be a test at the end of the day. So please remember that. But you don't need to know that, jokes aside. Careful about what is being reported, okay? Where the measurements are. And as I alluded to, just single dimension may not be enough. You may have to planimeter or contour the area, especially if your aortic root is eccentric, it is oblong rather than circle. The fact that you report one dimension means that you assume that the structure you're measuring is perfectly round. Anything short of that, you are making it a wrong assumption. That is what one of the shortcomings is of echocardiogram, okay? And as I told you, we have developed these new scenarios where we index not to body surface area, but to the height of the patient to develop thresholds, because height, unless you are really old and you're getting bone fractures and you're shrinking in height, vast majority of times the height, once you achieve the height, it remains stable. Your weight may fluctuate. Your body surface area may fluctuate. If the additional way, especially in younger folks or females where radiation is an issue, you can do cardiac MRI, which is pretty much very similar to CAT scan in terms of its information and ability to do imaging in a three-dimensional plane, and reconstruction in a three-dimensional plane. So MRI is also pretty much just as good. You can also understand the amount of leak coming out of the aortic valve. You can understand heart function. So there's advantages of doing MRI. The problem compared to CT is it takes a long time. Some of you who've had MRIs, it's like 35, 40, maybe up to an hour in a donut-shaped hole where you're claustrophobic and all kinds of noises happening. But it is a very good alternative. In fact, people would argue an equivalent alternative to CT scan if you can tolerate it. So Dr. Kalahasti has gone over the diagnostic criteria, so I'm not going to revisit that. But the important point here is assessment of the aorta is a crucial aspect of diagnosing Marfan syndrome based on the revised Gantt criteria. Okay? So in order for the product, the end product, to come out accurate, in order for the hot dog to look like a good quality hot dog, the stuff you put in needs to be right. Okay? So the aortic measurement is one of the most crucial aspects of assessment in terms of making a diagnosis of Marfan's. Okay? And Sagar has gone through it, so I'm not going to belabor the point much about the systemic score, et cetera. Some of the other things, some of you may have these, Ectopia Lentis, where there's lens dislocation. It is crucial, you'll be hearing from our ophthalmology colleague today, to have a full lens assessment, including a slit lamp exam, not just the Walmart optometrist who takes a look at you. No, you need a full-fledged assessment. Some of the orthopedic signs that you can see from imaging, basically lung findings, bony findings, chest wall findings. So where the chest is narrow, there's compression in the center or expansion in the center. And also some of the findings, orthopedic signs that are commonly seen in folks with Marfan syndrome. Other systemic signs, occasionally you will see patients who have lung blebs that ruptures and creates a condition called pneumothorax, where there's air. If it gets out of control, that can become a medical and surgical emergency. You can have pulmonary artery, so the right side structures get dilated. And the other common thing that is seen is there is expansion of the spinal cord, the structures within the spinal cord in your lumbar spine, known as dural ectasia. And of course, it is crucial, is it Marfan's or is it something else? Lois-Dietz, Ehlers-Danlos. Is it just some familial aneurysm without the characteristic features of Marfan's? So it is important to have a full-fledged assessment by a team of experienced providers, including a genetic counselor, to come to a crucial diagnosis. And imaging will help distinguish between different features. In acute aortic syndrome, it is crucial to have solid imaging. You need to be able to quickly decide, is it, if you have dissection, is it type 1, type 2, or type 3, or type A or type B? Type A is a surgical emergency. Type B, you have time on your hands. Type A involves the aorta close to the heart. Type B involves in the distal part of the aorta, so it is absolutely crucial to not waffle. Transesophageal echocardiogram, this is where you pass a probe into your food pipe and take pictures. This used to be a very common way of detecting dissections, but nowadays has been basically replaced by a CAT scan. You certainly, the top image, that structure, one is the valve, and the other one beyond the valve is a dissection flap. You do not want to have that because that's a bad thing, okay? Nothing good is gonna come out of that unless Roselli or someone like that gets in and takes care of business. Okay? Nothing good is gonna come out of it. CT, obviously it is universally available and rapid. It can distinguish between 3 different types of dissections. Not all CTs are created equal. I'm gonna show you a couple of examples. So that line going straight up, that's a dissection flap going all the way near your coronary arteries. That's a bad thing. If you don't fix that, your mortality increases by 1 to 2% per hour. Per hour. This is an example of a type B dissection where the thickening of the wall is past the neck vessels. So this is not as much of a surgical emergency. We can take our time and plan a procedure. Sometimes you may not have an obvious dissection. You have a tear that just blood is in the wall. But the implications are very similar to as if you had a dissection. It's called an intramural hematoma. CT is excellent for detecting all this. But you can still screw it up. The image on the left is where the technologists did not use something called a gating technique. This was an image performed at a smaller hospital where they do not have the appropriate software, or they don't like to use it, or they don't know how to use it. This patient was flown in with complaints of a dissection. We looked at that, we suspected that this is motion artifact. We repeated the CAT scan, we cured the dissection with just a CT scan, okay? It is poor form for us to send a patient to the OR. Roselli cracks open the chest and then say, Milind, what the heck are you doing? That was a motion artifact. So it is important. So especially for folks who are following your aorta on an elective basis, Patient education is patient empowerment. You need to ask your doctors, was my CAT scan done with gating? G-A-T-I-N-G, gating. Does the radiologist know to use 3D reconstruction to measure the dimensions? These are crucial questions you need to be asking. MRI, same way, but not too many of us use MRI in an acute scenario because time is money. And I've shown you some of the pictures. This is, we routinely do follow-up imaging to assess for complications as well as success of an operation. This is a CAT scan of a person who had a graft of the ascending portion of the aorta where the root was not involved. Or this is the CAT scan on the right of somebody who had a full-fledged Bentall procedure where we replaced the root, ascending aorta, and reimplanted the coronary artery. You better hope the surgeon is as good as Roselli when something like this happens, when you are reimplanting your coronary arteries. Certainly, you need someone like Roselli or Lars when you are doing valve-sparing root replacement, because this is a slick operation. A slick operation. And then these are some crazy images that I borrowed from Eric. You know, when I'm reading CAT scans on a Friday afternoon and I see and Eric has his outpatient clinic on Friday, and it's 3 o'clock and you see an image like that, you just want to shoot yourself, but say, be glad he's on our team because of the exquisite imaging. So this is where he's put a graft from the front all the way to the belly to avoid the dissection in the middle, or all kinds of crazy operations that we've seen over the years where the patients have done well and avoid disasters. And CT is by far the best way of looking at these patients during longer-term follow-up. So guidelines. If you are asymptomatic, you certainly need, to make an initial diagnosis, echo, tomography. You need 6-month follow-up, echo to assess progression, and an annual assessment using some form of tomography. If your dimensions are greater than 4.5 centimeters or growing rapidly, this is for all aortopathies, then closer follow-up. And of course, it is important, once you get diagnosed with a connective tissue disease, all the first-degree relatives need to be screened. All the first-degree relatives need to be screened, okay? Symptomatic, of course, if you are suspecting somebody is having a dissection, it makes sense to get the best possible imaging modality right away. Cutoffs. If you have, there was a question about atherosclerotic aneurysm. The cutoff is about 5.5 centimeters or higher. In Marfan's, it is between 4 and 5 centimeters. The number is a little loosey-goosey if you ask me, but if you are at a center like this, and I have confidence in my surgeon, which I do, I would trigger an operation much earlier than 5 centimeters. Certainly, if the aorta is growing at a 5 millimeters or higher rate per year, it is important to trigger an operation. But it is more important to be confident about the change. We have to measure the dimensions ourselves to convince ourselves that there is indeed growth, okay? And some of the other things, the last thing I say is we are starting to use area measurements, aortic area and height instead of body surface area for determining dimensions for surgery. So in conclusion, imaging is crucial, not only for initial diagnosis, procedural planning, and follow-up of all patients with connective tissue disease. Echo is the main first-line modality, but you have to be aware of its limitations. Tomography is extremely useful. Aortic dimensions have to be measured in a standard format. In suspected acute syndromes, time is money, and you have to go with the best strength of your institution. Most cases, it would be CAT scan. And tomography is very useful in post-op follow-up. Thank you so much.